So today we'll be discussing about some lesions of the breast which are benign and principally regarding breast cancer, clinical features, diagnosis, a little bit about principles of management. I will be going into staging at this stage. So a little introduction, I am Professor Mallika Tewari, and although my chief interest is hepatobiliary, but I have been assigned this task, so let's go through it. So there is something called Indian Council of Medical Research, it's ICMR, and it has its headquarters in New Delhi. So what it does is it basically collects a lot of data from all over the country and is one of the premier research institutions of our country. These days, it's doing some fantastic job regarding COVID as well. And so as far as our cancer data is concerned, it predicted that about 17.3 lakh new cases of cancer would be diagnosed in our country in 2020 and approximately 9 lakh deaths due to this. And overall estimate is that of 8 Indians, at least 1 is likely to develop cancer in their lifetime. It also shows that about 80% of our patients do not present in early stage. So overall, if we see in both males and females, especially in females, cancer breast stands as the #1 cancer in our country, closely followed by cancer of the lung, which is one of the commonest cancers in males. Cancer cervix, which supposedly was the #1 cancer in our country in females, has dropped to #3 now. And the other major causes of cancer in our country is related to use of tobacco in various forms. And it constitutes about 30% of all cancers we know. So if we look into the anatomy of the breast, most of it is composed of fat, all these yellow things that you see. And then there is a very intricate lobular structure. And breast, as you can see, it lies on a platform which is formed by various chest muscles. Why this is important is because there are diseases which can develop anywhere in the breast stroma, in this ductal system, and if there is a tumor which has grown enough, it can invade into the underlying muscles or the chest wall that we say. And all this or upside into the skin. So all this affects the staging of breast cancer. Inside what is there is that it's like a ductular and a lobular system, much like a tree and its lobules or leaves. In the next slide you see, actually if I can tell you, this area, it's called the TDLU. And why it is important is will be shown in this next slide. So TDLU is the terminal ductal lobular unit. Why it is important is because majority of cancers arise in this area. As you would imagine, the primary function of breast is to produce milk. And hence there are these bubble-like acini which selectively open into a duct which is called an intralobar terminal duct. And then it joins and becomes a little longer, and which is called an extralobar terminal duct. Now, hundreds of such ducts are there in the breast, which ultimately join the main latissiferous ducts, which are about 20 in number approximately, and they converge towards the nipple. So all this system, which is a unit, it's the TDLU. Clusters of 10 to 100 sac-like acini are there. And as you can see, it is a 2-layered structure. The outer layers are myoepithelial cells, and their functions, is their ability to contract. So once they contract, they push the milk from this produced in these acini into the latissiferous duct. Or principally, clinically examining the breast, it is divided by imaginary 2 lines into 4 different quadrants. And of this, there is an upper outer quadrant, upper inner quadrant, lower outer quadrant, and lower inner quadrant. And the upper outer quadrant has the maximum number of breast tissue and is the site of most of the diseases of the breast, including cancer. So before we head into cancer per se, there is something that you must know. It's called benign breast diseases, the new name for which is aberrations of normal development and involution. Now this terminology was coined by a great breast specialist, a surgeon, by the name of Professor Ellie Hughes. He used to work at Cardiff in UK and happens to be the mentor of my mentor, Professor H.S. Shukla. So what he basically proposed and is now widely accepted is over a period of life cycle of a female, it can be divided into three groups: the early reproductive period, the mature reproductive period, and the senescence or the involutory phase. As the patient ages, as a person rather ages, breast also undergoes various kinds of changes, some of which fall within the realm of aberrations and not disease, but if the aberrations are significant enough, they turn into a disease. Say, for example, we have many young girls in their teenage coming to us with small lumps in the breast, which is known as fibroadenomas, which is quite an aberration, but it's not normal, but it's not a disease either, right? Sometimes these fibroadenomas grow to such a big size that they are really a problem, what is called as giant fibroadenoma. Similarly, there is strobal development during puberty, and there is a chance that a few of the girls develop adolescent hypertrophy, which is all right. But suppose it grows to such an extent, it becomes a very huge single-sided hypertrophy, or sometimes even bilateral. It's called gigantomachia, which definitely needs to be looked into as a disease. Similarly, in the reproductive age group, there are certain changes in the breast, such as breast pain, some cystic changes. All these are part of normal cycle of the breast. But sometimes it becomes so significant that patients have to come to doctors seeking help for severe mastalgia, that is breast pain. Now, all this becomes a little away from aberration and hence has to be treated. Any infection, any abscess formation in any part of this syndrome period of years is definitely a serious problem. So if you look into it, what you understand is there are certain aberrations which may occur during development of the breast. Then during the normal, when the breast is completely developed, there are cyclical activities. And after 35 to 40 years of age, there is an involution. So as you all know, that breast is a hormonally dependent and a very responsive organ, and hence these changes become very significant. And abnormal things can be either benign or malignant. So we were talking about fibroadenoma, and it's commonly known as a breast mouse. Why? Because it's a localized aberration. Some tissues, they get proliferated at a certain place. It is not fixed to either the skin or the underlying pectorals and can be easily moved around in the breast. It's a very common condition, and generally we tend not to operate on young girls for not scarring their breast unless fibroadenoma is about 2 centimeters or so in size. And even then, it has to be very carefully removed using certain incisions which are hidden, like a periareolar or a subareolar incision. And the tendency to remove these fibroadenomas as and when they appear should be this. Then there are certain problems which do happen, as in this lady, you can see how many fibroadenomas are there, right? So there are some females who have a tendency to develop these fibroadenomas over and over again. You have to really counsel the patient that it is likely, even if we remove this, you may have it again. And hence, every time they fiddle with their breast and find a new lump coming up, it need not be removed. We define multiple fibroadenomas when they are more than 5 in number. It can be in 20s and 30s sometimes as well. And then various kinds of, there are Langer's lines around the breast which run in circles. So usually we plan our incisions accordingly so that scarring is minimal. Sometimes when fibroadenomas are very huge or multiple, we may use a submammary incision. Then I was talking about giant fibroadenoma. What is a giant fibroadenoma? It's when fibroadenomas grows to a huge size of more than 5 centimeters, as in this girl. And as you can see, it is not possible to remove this fibroadenoma through a periareolar incision. So what we do is make a subareolar or inframammary incision, which is also called Gillard-Thomas incision. And in this, the breast is completely lifted off the chest wall, and from beneath, the tumor is removed. Then something called a phylloides tumor, you guys must also understand. It's different from a common fibroadenoma. And I made a table for you to understand. Fibroadenoma is seen in young teenage girls, whereas phylloides tumor is seen in females about past their 40s. And fibroadenoma tends to remain static. However, phylloides tumor rapidly increases in size. As you can see in this picture, this is the huge phylloides tumor. But still, the overlying skin, although it is red and you can see all prominent veins, which are quite pathognomic of a phylloides tumor, but still the skin is free. You can really lift the skin, beg your pardon, of the tumor. Why it is important is because in cancer there is infiltration into the skin, which leads to skin being fixed to the tumor. And here, even if an ulceration develops, it's because the tumor is the breast tumor is stretching the overlying skin, resulting in decreased blood supply and eventual ulceration. Right? It's very difficult to differentiate on a basis of SNAC between fibroadenoma and phylloides tumor, and usually it will need a proper core needle biopsy or a surgical specimen. Why it is important to differentiate between the two is that although fibroadenoma can be removed by simple enucleation, that is, you can go right over the tumor, the fibroadenoma, and just scoop it out. But in phylloides tumor, we need to have a certain margin, which is a free normal breast tissue around this tumor, about 1 centimeter, so that it does not recur. And in some cases, it may even turn malignant. And then we were talking about some cystic changes which happen, and so I just wanted this slide to be shown so that you understand what are these simple cysts. So in a period, especially in the perimenopausal age group, patients might present with nodularity in the breast and lumpiness in the breast where there is no dominant nodules or any tumor out there, but there are these breast cysts. So if they are very small cysts, there is nothing to worry. They can be managed with counseling and some hormonal therapy maybe. If there is any, the size of the lumps are a little big, we may advise for a fine needle aspiration and cytology of the fluid. We generally advise it under ultrasound guidance. The largest of the cysts are aspirated till they are dry. 1 or 2 aspirations may be required. But suppose under ultrasound it comes out to be a complex cyst where there are solid components, etc., or the aspirate is hemorrhagic, then we need to do further studies to rule out malignancy, because perimenopausal age group is the age group where we find a lot of cancer. Right? So that becomes a disease, and simple cystic fibrocystic disease, which was the earlier terminology, is an aberration. Then patients also present with breast pain or mastalgia. It can be cyclical when it occurs at the time of menstruation, around the time of menstruation, or non-cyclical. So you must understand where the patient is complaining of pain. It's either on the breast parenchyma or on medially close to the sternum. So there are ribs, as you would understand, and ribs where they join the cartilage. So that's called a costochondral area, and patients do have pain in that, and that's a localized pain, right? So it can be tackled with local anesthetic injection. And then there can be lateral chest wall pains related to various chest wall muscles or underlying lung disease, which is completely different from a true breast pain. The other thing important is never to examine breast between the 4 fingers and the thumb. It should always be palpated with the flat of the hand. Otherwise, the normal texture of the breast is also nodular, and with a little more nodularity, it can cause various, doubts. So, a counseling for Andy is a major tool in treating these patients. A word about nipple discharge. Generally, nipple discharge are innocuous, and they accompany these cystic changes in the breast. See, here it is a serous, almost a watery discharge. Sometimes there might be a little bit of milk and other colors as well. So these are pretty innocuous. Where you should be understanding the importance of nipple discharge is when it is bloody and it is spontaneous. Patient doesn't squeeze her breast, there is a spontaneous staining in the undergarments and it comes out to be blood. Why it is important is because it may be a marker of an underlying disease such as a duct papilloma. Papilloma is nothing but a small tumor which comes up in the lactiferous duct. Or sometimes there might be a bigger tumor inside somewhere here, and causing bleeding into these latissimural cells. So generally, if we tend to do, I have a very low threshold of getting a nipple discharge cytology done, and more investigations are required if there is a bloody nipple discharge. So you have to differentiate between the severity of the symptoms of the patient before saying kuch nahi hai. So if we have a patient in the clinic, there are certain rules to examine any breast lump, which includes clinical examination, imaging, and histology. These are all complementary to each other and is famously called triple assessment, right? So now let's come to breast cancer. Breast cancer is a very common disease worldwide. In America, there is a very, very high incidence, about 1 in 8, if I'm not wrong. But if you see what figures we have in India, is about 1 in 22 women, which is still a high number, will get breast cancer in their lifetime. And the annual incidence is about 1.5 lakh new cases. So it's not as high as you see in North America or in Australia or in United Kingdom, but still, you see the light blue, it's still significant. We don't know why breast cancer occurs so commonly, but there are certain risk factors. It's a disease of females, but 1% of male patients also have breast cancer. So it's not like males do not get breast cancer. And in India, the peak is around 45 to 50 years, a decade earlier than seen in Western series. One thing we know for sure, if there is a strong family history of breast cancer or breast and ovarian cancer per se, then there is a high risk of developing breast cancer in the future generation. Early menarche, late menopause, number of childbirths and all this also are important. You understand why? Because they all tell for how long breast is exposed to these cyclical hormonal changes. If a lady has an early menarche and a late menopause and haven't had any children, naturally she has been exposed much more to the hormonal changes in the breast, and hence making her more predisposed for developing cancer. Although in our clinical practice, we see all breast cancer patients have breastfed their infants and have multiple childbirths, I really don't know how much water it holds. But certainly hormone replacement therapy or use of long-term oral contraceptive pills are red flags. Previous exposure to chest wall radiation, etc. is also there. What we really know is that certain genes such as BRCA1 and 2, which I must understand you guys also must be knowing, they are very much linked to cancer. So if there is a family history and it's a known mutation carrier, the persons, we have certain strategies for tackling this kind of patients. And then a lot has to do with lifestyle changes such as use of tobacco, alcohol, obesity, diabetes, which can be effectively controlled in anyone. So how does this breast cancer present? It can, in very early stage, it cannot be palpated or there may not be any symptoms, and it is detected just upon screening mammography. In late stages, there might be a lump, there might be a change in the size of the breast, there can be some skin changes, right? Nipple retraction, a bloody nipple discharge, an ulceration on the nipple, or patients may present with glands in the armpit. Here you see one of the patients with advanced breast cancer. As you can see, a big lump is pretty obvious. There is nipple retraction, right? And there are various ways to examine the breast. I'm sure you must be told in your clinics. But here you see patients with her arms raised over her head, and that makes a difference between the two breasts very remarkable. The nipple is at a higher level. And then this is a pudiorange, which is a skin peel appearance, and the skin is actually infiltrated by the tumor. Sometimes there can be a sitting ulcer right there as well. So coming to evaluation of a breast lump, clinical examination should be done, and every time, not only the breast, but axillary lymph nodes and the supraclavicular fossa must be examined, as well as any signs of edema in the limb or any hepatomegaly, which may be the signs of metastatic disease. Imaging, we have certain tools, of which is an ultrasound, a mammogram, and an MRI. Depending upon the situation, the usually we advise for a mammogram in a lady who is over 40 or 35 at least, and an ultrasound in younger females. Why? Because mammogram is basically an X-ray which shows radiation through the breast, as you can see in this figure. If the breasts are very dense, it's very difficult to make out anything inside the breast. And if there is, say, a young woman with a strong family history and a suspicion that she might be harboring breast cancer, the imaging of choice is an MRI in young women. Okay. The next comes is histopathology. It's nowadays a dictum to do a core needle biopsy in an obvious lump. This is a biopsy gun which is introduced not just over the tumor but away from the tumor, but still in the line of resection. You don't puncture right over the tumor, right? So as to cause any ulceration or seeding of tumor cells. And multiple cores are taken which are examined under histopathology and microscopy. And we can also do a receptor study in that. Depending upon these investigations, and obviously then we have staging investigations looking for metastasis in lungs or abdomen, ultrasound, which will all reveal whether a patient has a metastatic disease, bone scan and things like that. I'm not going into the details of which. So finally, we stage them as an operable breast cancer, a locally advanced breast cancer, and a metastatic breast cancer. So in generally, when we stage them as an early operable breast cancer, we can go ahead with direct surgery in such patients. Majority of patients now are coming in an operable stage, but still some are, still present in a locally advanced stage, which is still salvageable, right? So in these patients, we have a concept of giving them neoadjuvant chemotherapy. That is, we give a few cycles of chemotherapy to shrink the tumor, make it more operable before going ahead with surgery. As I was saying, any management in cancer, not only in breast, any management for cancer is not only surgery, but it has very important supportive and rather they act like colleagues, radiotherapy, chemotherapy, and in a few cancers, hormone therapy as well. The lady I shown underwent a mastectomy, which entails removal of her entire breast and clearing all the lymph nodes in her armpit, which we call axilla. So surgery means you have to treat, surgery in breast cancer implies you have to treat the breast as well as axilla. If breast lesion is small and patient has an early breast cancer and there are no nodes in the axilla, we have an option of saving her breast, which is called a breast conservation surgery. An advanced cancer such as this would entail a mastectomy. And in axilla, when we clear all the lymph nodes, it's called an axillary lymph node dissection. And again, when there are no nodes in the axilla or probably a few nodes only, small mobile lymph nodes, we can do something called a sentinel lymph node biopsy. So what do we mean by breast conservation surgery is, like you see here, there is a patient who had a very small breast tumor which has been marked. Only the tumor and a little bit of surrounding tissue has been removed. And there are various incisions depending upon the location. On the left side of the screen, you can see all these various kinds of incisions which are made to remove tumors depending upon the location of the tumor. And then the remaining part of the breast is reconstructed using certain oncoplastic techniques. That's why it's also called an oncoplastic breast surgery, and we have many fellowships around on the topic. Word or two about the sentinel lymph node biopsy. What is done in this is we have certain kinds of blue dyes such as isosulfan blue, methylene blue, and also radiocolloids. Now we have many other drugs also coming, dyes like indocyanine green and fluorescein and some other also that we use as contrast agents in MRI and all. So what the principle behind is that if we inject in the subareolar plexus of Seppi or peritumoral, this dye, it is picked up by these lymphatics, right? Because this is a pretty large molecule. So it is picked up in the lymphatics, and lymphatics go and drain into the first node that is next to the tumor. That is why it's called a sentinel lymph node. And as you can see here in this patient diagram onto the left below, that's a blue node. It's called a blue node where we had done using a blue dye. The other technician colloids are there, which is a radiocolloid guided biopsy, in which you could Usually, in centers they use both technetium, which is a radio-labeled dye, as well as a blue dye. But again, that is a radioactive compound and it has its own hazard exposure. So the person doing it has to be fully guarded with the lead apron and the thyroid guard and everything. And there are rules for its disposal, etc. So if the hospital is equipped enough, you can do both, and the yield is maximum with it. And to detect radiocolloid, after using radiocolloid, the sentinel nodes are detected with a camera which is called a gamma probe. You might have seen in many James Bond movies, they use certain kinds of big detectors to detect radiation. It's somewhat like that, a smaller one. So even after we remove the whole breast, which is called a mastectomy, there are ways to reconstruct the breast, which can be done by using an implant. Implant is nothing like, first we use something called a tissue expander to create that space. And then there is a silicone and various other kinds of implants which are available, which is put underneath the muscle. There are pros and cons of everything. Then there are certain local flaps which can also be used to produce a breast. It can be taken from the back, which is called a latissimus dorsi flap, or a transverse rectus abdominis flap, or perforator flap. All these are best done with the help of a plastic surgery colleague. Although many surgical oncologists are well versed with doing implants and an LD flap and an RMF flap, right? Then another terminology you guys must understand is something called a skin sparing mastectomy. As in this case, there are certain patients, as I was telling, who are carriers of BRCA mutation, who are destined to develop this breast cancer. So even before they develop breast cancer, they are advised to undergo, if willing, to have a breast removed. This is called a prophylactic mastectomy, and it's usually done called a skin sparing mastectomy. So the entire cover of skin is preserved, the nipple and areola, and the entire breast is removed. Now that whole gap is either filled up with an implant if the breast is small, or with certain flaps. So next, we'll talk a little bit of regarding prevention of breast cancer. It's very difficult to say primary prevention is possible. It's actually not possible, even if the patient has a genetic predisposition like a BRCA carrier. Still, after prophylactic mastectomy, there is a 3 to 5% of breast tissue which remains under the flap, and patient might land up with breast cancer. So primary prevention is not possible. What is actually possible is secondary prevention, where you detect the lump when it is still salvageable. So in this, we have definite mammographic screening protocol, whereas in India, unfortunately, because of logistics and economics associated, we cannot have any mammographic protocols. What we can best do is teach women to examine their own breast, which is called a breast self-examination. Now we have enough data to suggest, although there are certain controversies, there were initially two groups which said that routine mammographic screening was not helpful for patients because it detected small tumors which were never destined to develop into that kind of malignancy. It was low-grade tumors which were detected on screening mammography because you are doing it once in a year. So there is a 12 months in between. If there is a very aggressive strain, it will grow in between, and then there are chances of over-diagnosis and over-treatment. Suppose you find certain calcifications in the breast, then you will go and do biopsy, and the whole chain reaction happens. But now there is enough data to suggest that screening mammography does help in lowering breast cancer mortality. And as I said, in India, it's feasible, it's useful. If there are big questions because of the situation we are in. We are still a developing nation. Although we must remember it's quite a harmless procedure, a mammogram, where breast is put in between the two plates, and there are various new mammographic methods that detect very subtle changes in the breast, and the exposure of radiation is less than what you see in a dental X-ray. So if a patient is very apprehensive of getting a mammogram done, you may tell her that the exposure to radiation is minuscule. And what is seen in a screening mammogram is a specific type of calcifications, which are punctate and various different types. I won't be going obviously into the details of which that they tell that they are something is amiss and it's likely to be cancer. There are various other types of calcifications also which occur in senile patients, even some fibroadenomas. You can have popcorn type of calcifications, but a good radiologist will definitely pick up the benign ones from the serious. And in advanced patients, you can also see a tumor like that, which is called a spiculated lesion, right? So as I said, breast cancer screening guidelines are very much there in the UK, where women between 50 to 70 every 3 years, they are doing mammograms, sometimes annually as well, if there is a significant risk factors. American Cancer Society also suggests that women should undergo annual between 45 to 54 years of age. Breast self-examination is something which is available everywhere. It's only that the person has to understand how to do breast self-examination. It's usually done after the period when breasts are soft and supple, and with the finger, blunt tip of the hand, never between the thumb and the forefingers, which when the results can be abnormal. So why I was talking about prophylactic mastectomy and all that, I wanted to give you an example of this very famous lady who all must be knowing. Unfortunately, her mother and aunt both died of breast cancer, and they found that she herself was a BRCA1 mutation carrier. Now, as she came to know that she is already a BRCA1 mutation carrier, which confers more than 87% risk of developing breast cancer and more than 50% risk of developing ovarian cancer. So such individuals are advised to undergo a prophylactic mastectomy, which she did undergo, and she had implants fixed. And after completion of their family, they are advised to undergo a bilateral salpingo-oophorectomy, that is removal of the tubes and the ovaries as well. There are various other methods of risk reduction, which we call risk reduction interventions. When there are certain drugs like tamoxifen, etc., they do have a role, but primarily risk reduction intervention would include a total mastectomy with or without reconstruction. But again, the chances, the risk doesn't drop to zero. There is still some amount of risk, and these patients have to be followed up for a considerable period of time. Thank you.